Honorable Chairperson, respected seniors, learned audience, good morning. I am from Nepal, but I am made in Bangladesh, I would say. So today I'll be talking about standard of care in hormone receptor positive metastatic breast cancer, a real world experience from lower middle income country, Nepal. So the learning objective of our study was the first line treatment plans for patients with hormone positive, HER2 negative metastatic breast cancer based on risk assessment, the latest clinical data, approvals, guidelines, and expert recommendation. So we wanted to see whether these published data are fit for the low middle income country like Nepal or not. So this is the algorithm to guide the first line systemic therapy selection in HR positive, HER2 negative metastatic breast cancer. When anyone diagnosed with a stage 4 metastatic breast cancer, we see two things. First, the patient has a significant visceral crisis or not, or if the patient is very old, if she has any kind of comorbidities or any frail, then after segregating in that matter, we will see for whether the patient had a BRCA mutation or not. If the patient has no BRCA mutation, then we see whether the patient is fit for the endocrine therapy with CDK4/6 inhibitor or not. So what is the clinical significance of CDK4/6 inhibitor in HR positive, HER2 negative metastatic breast cancer? We know that there are so many data showing that after the introduction of the CDK4/6 inhibitor, the median PFS has increased to 2 to 3 years in front line compared to less than 1 year when we had only chemotherapy option. So based on this data, now CDK4/6 inhibitor plus endocrine therapy is now the standard of choice first line treatment in the metastatic setting as per the NCCN, ESCO, ESMO, and I'm sure in future we'll have a SARC guidelines. So there are several data. I think I can't go very detail on those studies, but if you see the best phase 3 trials like Paloma 2, 3, Mona Lisa 2, 3, 7, Monarchs 2 and 3, all these data say that these CDK4/6 inhibitors, when added with the endocrine therapy, they show the better PFS and OS to all those patients who are HR positive, HER2 negative metastatic breast cancer. So, but how do we select which CDK4/6 inhibitor is the best? So, if you see this summary data, this was that Mona Lisa 2 and Mona Lisa 7 had a little bit better overall survival compared to other trial. More than that, if you see the hazard ratio there, the hazard ratio is less than those Paloma and the Monarchs. So based on this, I would say that this has a more significant, clinical significant data based on these trials. So how do we choose the best CDK4/6 inhibitor? All this data shows that ribociclib has the highest level of evidence, but we have to keep in mind that all three agents delay the time to chemotherapy. So the drug which we are studying now is in our country is about the ribociclib, which we also call the Kisqali. This is the drug from the Novartis. So this has a 200 mg tablets. We start with the 600 mg, and then the dosing schedule is once daily for 21 days. It's a 28-day cycle. We can consider on the food, with or without the food. And the major side effect what we have seen is neutropenia and fatigue. But we also have to monitor every monthly CVC, LFT, ECG and electrolytes. The special concentration should be given to QTC prolongation and then hepatic toxicity as well. So what are the patient factors? We know that beside these drug factors, we also look for the endocrine sensitive or the resistant disease if they have already used the endocrine or menopausal status. You know that out of all these studies, only Mona Lisa 7 has trial with the premenopausal population. Otherwise, all the population had the postmenopausal study group. And then we also look for the visceral crisis, performance status, and also the important thing is comorbidities. So our study design was single center prospective cohort. We stratified whether they had the patient has a liver, lung, CNS or other metabolics. And then how many prior chemotherapy they have taken, or whether they have taken endocrine therapy or not, or if they are the premenopausal GnRH analog has prescribed or not. All these factors we have seen. So our patient character, the median age group was 45 years. The education level was the most of the patients were high school graduate, followed by illiterate, graduate, and then very few were, I mean, like they have done the masters and above. And the most of the patient has a equals performance status of 1, followed by 2, and then 0. So by age distribution, the maximum number of patients were above 50 years old, followed by 40 to 50 years, and then less of the patients were below the 40 years, only 12 patients. And in our the group of the patient, we had the maximum number of patients of postmenopausal, followed by 35% of the premenopausal. So what about the prior treatment status? Our patient, most of the patients were already in prior neoadjuvant or adjuvant endocrine therapy plus minus chemotherapy, and 30% of the patient had a prior chemotherapy, surgery, and also radiotherapy, and only 16.7% of patients had no prior CT or NACT, and most of these patients were from the very rural area of the country. If we see the characteristics, like we had a total number of 60 patients, out of them now 52 patients are still on ongoing treatment. We had a one patient who had a disease progression. For that reason, we have to discontinue the treatment. Then we had 6 patients who died. Some of them died because of the comorbidities. And then one patient was lost to follow-up. She was from the very remote area. If you see the site of visceral metastasis, most of the hormone-positive metastatic breast cancer have the bone metastasis. We have almost 63% of the patient with the bone metastasis, but we also had patient 20% with the lung metastasis, 10% with the liver metastasis, and 5% with liver and lung both metastasis at the time of presentation, and we had a less than 2% with the CNS metastasis. If we see the trend of number of patients on CDK4/6 inhibitor plus ET, that means how we enroll. When we started the treatment on November 2023, we had only 3 patients enrolled. Maybe because of the advertisement, or maybe we told to all the media and even all the hospitals, we sent the information that CDK4/6 inhibitor is freely available in my center in Nepal. So maybe then came to know about that, so our number of patients surged in December, almost 11 patients. Then again, I don't know, maybe because of the winter, January, February, March, April, we had a less number of patients, 2, 3, or 4, 5. And again in July, August, again we have a maximum number of patients, almost 11, 12. So till now, up to the study of November 24, we have now almost 60 plus patients in ribociclib and letrozole. So these drugs are freely available in Nepal. To conclude my talk, I would say that even we sometimes have a confusion regarding the guidelines. There is a significant improvements in progression-free survival and overall survival in HR-positive HER2 metastatic breast cancer with CDK4/6 inhibitors combined with endocrine therapy. So I would say, like, I agree with these guidelines. Patient-specific factors such as menopausal status, comorbidities, and disease sensitivity to endocrine therapy are critical in selecting the optimal treatment strategy. We know that these studies or these guidelines demonstrate applicability of global guidelines and therapies in low and middle income country like Nepal with promising outcomes. But we need to keep in mind that regular assessments and patient-centered approaches remain crucial for improving clinical outcomes. So to conclude in one sentence, that these findings reinforce the pivotal role of CDK4/6 inhibitor as a standard of care for HR-positive, HER2-negative metastatic breast cancer, underlying the importance of integrating evidence-based practice even in resource-constrained settings like Nepal, maybe someday in Bangladesh as well. So I would say this is the new milestone in Nepal, and I am very much grateful to my hospital, that is Patan Academy of Health Science, and the Max Foundation, the USA. They are providing free medication for this our patient. And I am sure that you all know that the cost of ribociclib, that Kisqali, the Novartis one, is almost more than 1 lakh rupees per month. So we are getting it in free, and I am very thankful. And thank you to the organizers for providing me this opportunity. Thank you very much.